Very good afternoon to everyone. Hope all of you had a good lunch. Yes, no? Okay, so definitely post-lunch sessions are always a little bit challenging, but we'll make sure that with this distinguished panel here, we'll make it as interesting and useful to all the participants and delegates who have joined this session. I can guarantee that, because the kind of wide experience this panel brings in, it is, will be quite interesting to see how different countries and different states have ensured a lot of innovations in terms of provider payments and what learnings can PMJAY gain from these experiences. So with that, I request Trina S. Huck, who's our Health, Nutrition and Policy Practice Manager, South Asia from the World Bank, to give her opening remarks.
Hello. Good afternoon, everyone. It is a great pleasure for me to be here. This is the first time I'm joining the Arogya Manthan, and it looks to be an amazing gathering of professionals who are dedicated to improving the health system of India, and it is a great honor for me to be here as part of this panel. So first and foremost, I would like to take this opportunity to congratulate the Government of India, especially the National Health Authority and the state health authorities, for 4 successful years of implementation of PMJAY. It's really laudable how far PMJAY has come within this very short time span of 4 years in expanding health system coverage and serving the UHC agenda in India. It's truly a time for celebration and reflection on the journey so far. I'm really impressed that every year NHA organizes the Arogya Manthan and leads the efforts to take stock and reflect on what is working well and what is not working quite as well as we would like it to. I understand that this also provides an excellent opportunity for state health authorities to share their experiences and also to gather evidence and hear about experiences from different countries globally. At the end of the day, what we're trying to do is to really synthesize all of these lessons into mechanisms that can improve the ability of the PMJAY to really do its job even better than what it is doing currently. As part of these efforts, building on the strong foundation of the implementation of PMJAY in 33 states and union territories, the focus of NHA is increasingly on quality, strategic purchasing, and efficiency. All of these are absolutely central to ensuring better health outcomes and better efficiency of the overall health system of India. So as we engage further in the discussions on how to strengthen and take forward this agenda, I am really reminded of the potential of PMJAY to influence and shape India's health system for improving access to and quality of inpatient care, especially in terms of reducing catastrophic expenditures for households and improving health outcomes for the poor, including by giving them a choice to access private care. Given the large scale at which it operates, how a scheme like PMJAY pays health service providers and provides incentives for ensuring quality, efficiency, responsiveness, and long-term affordability, it can really improve and influence the entire health system, going well beyond PMJ. This can also help to reduce the extreme level of fragmentation in service provision that exists today. Prioritizing expanded engagement with providers and ensuring quality of services with the existing providers are key strategic priorities. We know that different provider payment models create different incentives or economic signals that can influence provider behavior in achieving improved quality, efficiency, and value for money. Today's session focuses on models and experiences of different provider payment models across the globe and their suitability in the Indian context. Under PMJ, accredited hospitals are currently paid on case-based bundled payments for most procedures, per diem, per day package rates for certain medical packages, and line item budget and additional package rates for public hospitals. The analysis has found that this system is not immune to upcoding. In other words, the incentives currently appear to be to increasing the length of stay for medical packages and inclusion of additional codes by exaggerating clinical conditions, all to improve the reimbursement to the hospital for that package. To overcome such challenges, we're going to discuss this afternoon what other countries are doing to tackle this issue and the approaches that they are taking by implementing the case mix tool based on groups of diagnoses and procedures. In other words, diagnosis-related groups or DRGs, a journey that the NHA itself has also embarked on in partnership with the rollout of the DRG pilots in 5 states. Furthermore, we will also discuss what value-based healthcare payment models that center on incentivizing patient outcomes can do in terms of improving the quality of care. I would now like to hand over to Dr. Sudha Chandrasekhar to lead the discussion amongst our distinguished panel members and to help gain insights related to different payment models to understand what can be most suitably adapted to the Indian context so that we can really incentivize providers to provide high quality care and increase the utilization of PMJ. This will not only help to reduce the economic burden on households from out-of-pocket expenditures, but also generate savings for the PMJ scheme and also improve health outcomes. Thank you, and over to you.
Thanks, Trina, for that excellent overview of the session and the kind of background in this topic. I'll initially start with Dr. Ajay Tandon, lead economist from the World Bank. Even today morning, we listened that our Honorable Health Minister specifically mentioned that we need to move towards quality of care and keeping patient-centered delivery of services, along with other stakeholders who are our states, our hospitals. So in that sense, based on your global experiences, especially for inpatient care, what are the different payment models that will be very relevant for PMJY? And how do you think these successful models can be replicated for the Indian context?
Thanks very much, Dr. Sudha, and also thanks for the introduction by Trina. So let me just start by speaking a little bit more generally. You mentioned incentivizing quality, but I just wanted to also make the point that lack of quality, so especially in public service, publicly delivered services, also is one of the primary reasons why we have very high out-of-pocket spending, not just in India, but in many low-income and lower middle-income countries. So high out-of-pocket spending is partly a reflection of low quality of care, especially in public facilities, which in turn is related to low levels of public financing. So quality is not just about improving outcomes and what happens when you're hospitalized, but also it can have an impact on health more generally, on how a health system is financed. The other point I want to make that is in terms of conceptualizing quality, typically you have these three big buckets. So most people look at what is called structural quality. Structural quality is really the availability of equipment and human resources. You have process quality, that is the extent to which the sort of the inputs are being used, and then you have quality that's related to final outcomes, the extent to which the patient actually recovers or improves their health. Three big buckets of quality: structural, process, and outcomes. And also to make the point that earlier on, say 15, 20 years ago, quality referred only to clinical quality. In fact, WHO, when they did the World Health Report in 2000, they explicitly separated clinical quality of care from patient experience. They used the term that was used at that time was responsiveness. Whereas more recently, when you say quality of care, you don't only mean clinical quality of care, you're including the patient experience, such as waiting time, whether the doctor smiles at you, and things like that. So the non-clinical aspects of quality are now also embedded more recently into what is considered to be quality of care. And as countries become richer, grow faster, Jack was mentioning India is the fastest growing, there's also a greater demand for higher quality care, including better clinical quality, but also better responsiveness, lower waiting times, and the like. And so unless quality keeps up with the demand, you're going to have these negative adverse effects in terms of how the health system is set up and runs. In fact, I recommend for those of you who are interested in this to look at there was a recent Lancet Commission on high quality health systems, and I think one of the key points that the Lancet Commission made was there has been a lot of progress in terms of improving coverage of services globally, but really now the focus of health systems should squarely be on whether or not that coverage is effective. So really the quality should be central to how health systems are organized and operated. And Dr. Jalani in the last session referenced the SDGs for universal health coverage. There are actually two sub-SDGs under the universal health coverage measure. So one part measures service coverage, the other part, the SDG 3.8.2, measures financial hardship. So the way a health system is financed also matters, because if you have very high out-of-pocket spending, that it deters and delays necessary care, it impoverishes people when they do seek care, it also is a very inefficient and inequitable way of financing health systems. And the point I wanted to make is that there has been a lot of progress made on improving service coverage. So more and more people are, more and more women are delivering at institutions, immunization rates have gone up, a lot of other progress on key basic indicators. However, financial hardship has been going in the wrong direction. So even though service coverage has improved, financial hardship globally as well as in India is going in the wrong direction, in that more and more people are having to pay out of pocket to access health care, and part of the reason of that is low quality of services. And also to make the point that health financing is only one lever. I feel bad saying that as a health financing person, but really health financing is only one lever to improve quality. There are a whole lot of other things that you may have to do in terms of improving governance, in terms of training, in terms of health technology assessment, so that what gets included in your benefits package to begin with is intended to have high-value effects on health outcome. And in many countries, including in India, the structural quality component is often built in. So, for instance, empanelment, only using accredited facilities with a minimum number of beds, or a minimum number of staff, or a minimum number of volume of services that are conducted is often the first step in trying to utilize the health financing lever of providing coverage, but providing coverage only when facilities meet a certain minimum standard, which is already happening in India. And as Trina made the point, that the problem is that many traditional provider payment mechanisms that are in place, like in public service, public delivery, you have line item budgeting. In the private sector, you have fee for service. So these traditional provider payment mechanisms typically don't incentivize quality. They emphasize quantity over quality, or in some cases there is no explicit focus on quality, so the quality angle gets dropped. To put it very crudely, the way current financing mechanisms or provider payment mechanisms are set up, including case-based payments, the providers then, the sicker you are in the population, the more the providers tend to get. So it's almost an incentive for the providers to make you as sick as possible, because that means more utilization. But more generally, what you want to do is you want to incentivize the providers to keep you healthy. So that sort of it sums up, what you want to do in terms of amending your provider payment mechanism. So not to give the providers an incentive to go after volume. The sicker you are, the more money they make, but to really on value. So the healthier you are, the more money you make in the population. So that sounds very simple and easy, but not very easy to implement. It's basically about ensuring that the right services are provided at the right time, at the right level of care, and also at the right prices. So all these factors have to come into play. And rather than saying that there's one typical model that works in terms of incentivizing quality, just want to give you examples. There are 3 buckets of ways in which the world is trying to improve quality. The first is keeping the sort of the traditional provider payment landscape the same, but just making some amendments. So you will still perhaps have line item budget, but you still might have case-based payments. But then on top of that, you incentivize providers by perhaps tracking things like waiting time for surgeries. I'm just giving you the list from the UK, or readmissions within 30 days. So you sort of adjust the payment mechanisms so that if you feel that the quality of care, including waiting time or clinical quality, is not up to par, you begin to penalize providers or to incentivize them. Hospital-acquired infections is another common indicator. Mortality rates after some surgeries. In some cases, looking at survival rates after, say, cancer surgery or prostate surgery, for instance. And also to look at things like to what extent are C-section rates happening. So more generally, when you think of a hospital, you want to make sure that the right people who need to utilize the hospital are coming in to begin with. While they're in the hospital, they get optimal high-value care and don't end up getting infected by something else. And also that they are discharged at the right time. They're not kept too long in the hospital, but are also not discharged too early. So sort of these 3 components are important in terms of incentivizing and measuring quality of care. And I just want to emphasize, it's also important to see who's coming in. So are people who are coming in for inpatient care, should they be coming in? Because you can have a very efficient and very high quality hospitalization program, But if you're treating people who could have been better treated at the primary care level or could have been prevented, that's also something wrong. So you want to also look at who's coming in and why. Is it because air pollution is very high, so your COPD inpatient hospitalizations are going up? What's the point of being very efficient in treating COPD when you also need to address what's causing that hospitalization if it is preventable? Or for conditions that are ambulatory care sensitive, there are conditions like diabetes and asthma and hypertension could be treated with good quality primary care should they be coming in. And once they come in to look at whether they are getting the right care, and then after discharge that they're not being readmitted and they are healthier. So that's sort of one big chunk of ways in which countries do. They keep the traditional payment mechanism, but they add on some incentives for quality. And just very briefly, I'll mention two other ways in which quality are being incentivized. And I think maybe Robert and Jack will talk a little bit more. The second really is looking at bundled payments. And bundled payments, I don't mean bundled payments in terms of DRGs. DRG is also a bundled payment. When I say bundled payment, I'm meaning payments that span different levels of providers. So there is now a move, and this is also a move away from paying not just the providers, but really thinking about being patient-centered. So in many countries now, if you're diabetic, a group of providers gets together and they're given a sort of a fixed rate to treat anything that you may end up needing for being diabetic or for being hypertensive. Whether you need hospitalization, whether you don't utilize care or not, you get a fixed amount as a provider. So it then becomes in the incentive of the provider also now to keep you not utilizing care, not by skimping on care, but trying to keep you healthy, to try and keeping you adhering to your medicines, to try and keep you on treatment. So some ways in which turning the whole payment landscape on its head, which in its sort of a natural evolution takes us to global capitation models. Very simply, a global capitation model is where anybody who's empaneled with a group of providers that provide all kind of care, they get a fixed amount for covering that person, regardless of whether that person is healthy or sick. So suddenly now the providers will get to keep the money that they're getting for covering a certain person, regardless of whether that person comes to the hospital or not, or regardless of whether that person utilizes. So again, the incentive changes for the providers now to keep you healthy and to keep you out of the hospital and to treat you early and at lower levels in a more cost-effective manner. Just to give you sort of a sense of the logic behind how these provider payment mechanisms are trying to turn the traditional provider landscape around to try and incentivize by building into the way providers are paid an incentive to keep the population healthy, rather than getting paid more the sicker the population is.
Thanks, Ajay, for giving an overview of the different payment models and also how that links with the quality of care, and also emphasizing one critical point that is about primary care and avoidable hospitalization. So that is how do we incentivize that for the providers so that we get good outcomes, and also we ensure that we move towards a kind of a bundled payment system with different levels of care. So I think with that global experience, I would like to move to Jack. Basically, Jack, you have co-authored the book on transitioning of countries to DRGs, the diagnosis-related groups, and also helped many countries actually implement the diagnosis-related group. And as you're aware that PMJAY and NHA have launched this pilot for diagnosis-related group for our scheme. So what are the two most important learnings from your experience that we should look for and ensure that we use that to cut our learning curve and also avoid making any repetitive mistakes? So in that sense, your thoughts on that?
Thank you. Thank you, Dr. Suda, and thank you, Trina, for these wonderful introductions, and thank you, IJ, for setting the stage in terms of payment reforms. Now, I am really delighted to know that PMJAY will be moving, or at least piloting, the DRG system. That's a very exciting phase. I think that you will be able to develop a payment system that is fair, also greater transparency, but it's not going to be necessarily easy, and we see countries taking anywhere from 3 years to 10 years to implement the DRG system. So you don't want to go too fast. You want to go at the rate that you can, analyze the data, collect the information, develop the costing, develop the coding infrastructure, the expertise, the impact analysis, because hospitals will transition from one payment to the next, and they'll need time, and they'll also need assurance that they're not going to be losing revenues, at least initially, in the early years. Now, I will mention one country where I worked in East Asia that implemented DRGs in 2014. And there are a couple of lessons that come out of it. First of all, they didn't have enough time. They didn't have enough time. The president said, I'm leaving office on January 1st, and I would like you to implement the entire health reform new system in 1 year. So they went about doing the best they could. I think they, with the time constraints, they chose to go to an outside organization. An outside organization in Malaysia. It was a good organization, but the organization in Malaysia used a grouper from the United States. The grouper from the United States, as you might suspect, was based on costing structures in the US and also based on protocols, pathways in the US. So they developed the DRG system for this country, but of course the prices from this grouper didn't match either the clinical protocols or the costing structures in this country. And so there was a mismatch. There was a mismatch, and hospitals were confused, they were disappointed, and of course they pointed out quite rapidly that their prices were not equaling their cost. So what I would say to you is do it yourself. That's the first lesson here. Do it yourself. You can find firms in Germany, you can find firms in Malaysia, you can find firms in the United States who will do this for you. But I don't think you want to do that. I think you want to do it yourself. Don't undersell yourself. India has lots of experts. I never worry about expertise in India. Develop your costing data. Develop your information systems, which you're doing, of course. Look at your pathways. And take a grouper and modify it to the India experience, okay? That's what you want to do. You don't want to contract it out. The other problem with contracting it out is you don't build capacity. You need a team to be constantly looking at how it works, constantly updating it, because we have new pharmaceuticals, we have new devices, we have different clinical protocols that come online. The DRG system has to be adjusted either annually or biannually. And so you need this team in place to constantly be doing that. The other problem you have, or the other challenge you have, is that hospitals will be knocking on your door and saying, hey, you're not fair to me, and here's my data. And so you're going to have a team there to actually look at their data and to say, well, here's our data, and either you know, you are being paid fairly, or maybe there's an adjustment that needs to be made over time. So you need that capacity in-house. So that's my first point, very important point, do it yourself. And I think India won't have any problem doing it yourself. Second issue is, in this country, is that they didn't really have a well-developed IT information infrastructure. And so going to IJ's point, you know, they didn't have a good IT infrastructure, and so they could pay claims, but they couldn't measure quality. They couldn't measure performance. They didn't have the individual individual patient numbers. They didn't have the individual provider numbers. They did that over time, but initially they didn't have the information infrastructure to really track quality. So basic indicators, IJ mentioned readmissions. They couldn't track readmissions. Now, in my country, in the United States, readmissions were 19%. 19% of the people who were admitted and paid on the basis of DRGs were readmitted within 30 days. So they had to pay twice. You really need to track indicators like that very closely. So your IT system is essential, and that is hooked in, or that correlates directly with quality measurement, and accountability. So those are two very important lessons that come from another country here in Asia.
Thanks, Jack. Definitely, yes, I think we would be very happy that we have that kind of a learning and an advice quite early in our process, because we don't want to move ahead in a wrong direction. And based on that, I think we are embarking on having a good costing data, good coding data, which are very, very critical for any kind of advanced provider systems to work. So with this, I would like to move to Robert. Robert, Maryland had implemented several innovative provider payment mechanisms under your service. And if you could share some of the challenges you faced in scaling those initiatives, and what is it for India? What kind of learnings are there for India?
Great, I'll try to do that. First, I wanted to provide just maybe a little context for you about the Maryland system. Maryland's a relatively small state. It borders the District of Columbia, which is the nation's capital. Like most states in the United States, back in the 1960s and 70s, we had tremendous cost growth, hospital expenditure growth, and also issues with regard to declining affordability of care and access to care. There were large swaths of patients that couldn't afford insurance, and that generated large amounts of bad debt for hospitals. So in response, Maryland and several other states passed laws to create a regulatory system to set prices for hospitals to try to address the key policy goals. These are the similar policy goals to what you have here. We had a big cost growth problem, so that perhaps is a little different than what exists here in India. But we also needed to improve access, improve quality of care, improve the equity and the transparency of the system, and it also enhance the financial predictability and stability for hospitals. So those were our key goals that were implicit in our legislation. Our system set rates for the 50 hospitals in the state, the general acute care hospitals. We just set rates for facility services only, not physician services. And it covered a wide range of hospitals, all the way from the large academic medical center of Johns Hopkins, which you, I'm sure, heard of, as well as down to suburban, urban facilities and small rural facilities. The pricing system was also unique in that it mandated that all hospitals and all insurers participate, and that included both the public payers, Medicare, we'll hear from a little later, and also Medicaid and the private insurers. Now, the core element of the Maryland system really was the DRG adoption, which we were the first jurisdiction in the world to adopt DRGs back in 1976, and that remains a core element of the payment system today. And after starting the agency, we began the process, as you are doing now, of intensive data collection, primarily hospital volume and cost data, from which we developed a system of bottom-up costing, that being the importance of having accurate cost levels to set prices that reflect costs and also cover costs, makes for a more efficient allocation of resources and also adequate payment for hospital care. We've faced a number of challenges and some resistance from hospitals early on in implementing the system, but very quickly hospitals found the system very attractive because it was well understood, it was transparent, and it developed a common language across clinicians and administrators that they could use to communicate to improve the care delivery. Now, using DRGs, we successfully controlled hospital cost growth, which again was our primary objective because of large increases in hospital expenditures. But DRGs in other countries can be used as a means of promoting activity, hospital activity, to be responsive to the needs of patients. So that's another important element of the DRG system. In Maryland also, DRGs actually did improve hospital financial performance. While DRGs set a payment cap by type of case, in Maryland, it also provided a revenue guarantee for each case that a hospital treated. And that's why we named our system, the DRG system, the guaranteed inpatient revenue system. The hospitals liked that concept because they knew what that price was they would receive if they could lower utilization, lower costs, they could generate surpluses that they could use to reinvest in needed technology and other equipment and be more responsive to the patient care needs of hospitals. So that's a key point, that operating efficiency improvements generate financial sustainability for hospitals under a DRG system. As mentioned, as Dr. Suda mentioned as well, we did move to evolving a system of payments, broadening the bundle of services under payment, most specifically adopted hospital global budgets for a group of 10 rural facilities. And the idea there being that these hospitals served more contained patient populations, and they liked the idea of having a stable, fixed, preset amount of revenue that they were guaranteed during the course of the year, regardless of patient utilization, so that they could be very predictable in terms of the amount of revenue they generated and serve their populations more effectively. If, again, just like with DRGs, if they could reduce utilization, unnecessary admissions, unnecessary tests and procedures, and also improve their operating efficiency, they could generate surpluses that could be reinvested in preventive care, primary care, to improve the health of their populations over time. And then subsequently the following year, do the same thing over and over again. And that was a system that worked very well, as I said, for the 10 rural hospitals. Now, in addition to global budgets, we also early on implemented a system of quality improvement. It's been mentioned earlier about processes of care where we added incremental penalties and rewards in the payment system for adoption of things like aspirin on admission for heart attack patients, adults smoking cessation, beta blockers upon admission, prescribed upon discharge, those sorts of process measures, but then moved very quickly to quality measures that penalized or rewarded hospitals for higher or lower rates of readmissions. And with the DRG system, as mentioned, you can track patient readmission over a 30-day period and then build in rewards or penalties into your payment system. Third, there was also an emphasis on rewarding hospitals for improved incidence of preventable hospital complications or hospital-acquired conditions. These are conditions that were not present on admission, but that were acquired once the patient was on the ward, and as a result, it was the responsibility of the hospital. Things like pulmonary embolism, renal failure, infectious complications like septicemia, and post-wound operative infections. There were 64 of these preventable complications that hospitals were rewarded or penalized on based on their individual performance. Now, this was enabled by the extensive DRG coding system, which encouraged hospitals to, for payment purposes, to completely code secondary diagnosis. So then we expanded these types of incremental reward systems to include to reward hospitals for reduced patient mortality rates, reduced rates of ambulatory care sensitive conditions, to encourage them to get out in their communities, work with primary care physicians to increase preventive and primary care and avoid these admissions, improved patient satisfaction rates, reduced emergency room wait times, which was an issue for some of the hospitals under the global budgets. And so those sorts of things worked very effectively, and we were able to both increase the quality of care as well as incentivize hospitals to be more efficient and at the same time provide predictable revenues for the hospitals under our payment systems. It certainly was not without challenges. I very much congratulate you on undertaking this mission of expanding your insurance system to a broad swath of population in India. And I would suggest that once you have completed your mission, that you come to the United States and show us how to do it, because we are still struggling with this issue of universal care and access in our country. Thank you very much.
Thanks, Robert. Definitely, you have given a good idea that it need not be one type of payment systems. Especially, you need to have a mix to reach out to the specific type of hospitals and also for this kind of services that the hospitals are providing. So it's good that we don't have to have, all or none phenomenon or taking that kind of a decision of having a single kind of payments. So we can work out something which will enhance the performance of the hospital for specific type of services. So thank you, and I just want to check if Dr. Purva is online. Yeah, I saw her, yes.
I'm here.
A very good morning, and I think it must be very early for you in the morning in the US. Thanks for joining to us, and Dr. Purva Raval is the Chief Strategic Officer at the Innovation Center at the Center for Medicare and Medicaid Services. And today we have her to share her experiences of how we can inbuild the value-based care and incentives to enhance the hospital performance. Recently, NHA has also released the report on the value-based care and incentive policy. So we are looking for how do we implement this policy and what learnings we can have based on your experiences, so that again we achieve that in a much shorter time. Over to you, Purva.
Can you hear me?
Yes.
Yes, okay, great. Good morning to all. Well, good afternoon to you all. It's morning for me. But I just wanted to start by saying thank you to Dr. Chandrasekhar for the invitation to be here today, and to Bharti for her assistance in making sure I got here on time. And congratulations to all of you who have been on the PMJAY journey for the past 4 years. Got to learn a little bit more about your work in India and the work that you're doing to bring access to hospital care to more Indians, and now to be thinking about the quality and the outcomes of the people that are being served through the hospital system. And so, it's 4 years is not a long journey. I think others on this panel have described how long we've been on the journey in the United States, but you all are undertaking quite an effort, and just I'm happy to be here with you all to share a little bit about our work at the Innovation Center, and then to see how it might be helpful and useful to you all. And hopefully it's the beginning of a dialogue and a conversation. And I'll also just say it is quite early here, but when I told my mother I was going to be doing this, she was quite happy. So I think there's a lot of parallels to our work in the United States, where you all are in some ways lucky because you are designing a new system, whereas we are redesigning our system. All the way from acute inpatient care to outpatient services. And Robert described a little bit of the journey in Maryland. And Maryland actually, the payment system in Maryland operates under a waiver that the Innovation Center actually runs. And so we work very closely with the state of Maryland on the work there. But you can see how there you're trying to redesign a system and redesign incentives all the way from acute inpatient care to outpatient services. And the goal here is really to get the results that hopefully patients want to achieve, not just providers in the system. And so at the Innovation Center, we test models and demonstrations to move the health system away from fee-for-service payments that drive or measure utilization towards value-based payments, as Dr. Chandrasekhar was saying, that drive better health and outcomes for individuals and families. And so for those of you that are not familiar with the Innovation Center, I'll tell you just a little bit of background, and I think it'll give you a sense of what we do and what our scope is. The Innovation Center was established 12 years ago in the Affordable Care Act, which is our last big health insurance reform law in 2010. And the statute, that law, explicitly provides the Innovation Center the authority to test innovative payment and delivery models that, again, move us away from fee-for-service spending to a payment system that supports better health and outcomes for providers. And the goal of our models is to, again, preserve or enhance the quality of care for beneficiaries while spending the same or less. So you heard a little bit about, overutilization and healthcare spending in the United States, where, we sort of had these dual, multiple problems with, in some cases, high spending, in other cases, lack of access in many communities as well. And so I'll talk a little bit about some of the work that we're doing in the equity space, because we know that access is not the same for all individuals. So what we do is we test alternative payment models that, again, give providers those incentives to deliver high quality, cost efficient care. And so part of that, others spoke about quality measures, and I can talk a little bit at the end about where we're headed with quality measurement as well. Again, in a way that's not just tracking utilization, did somebody get X or Y, but how did they do because of that, the care that they received. In that first decade, the Innovation Center, we've launched and tested over 50 models, and we have almost close to 25 operating right now. We have a lot of learnings in that first decade of how do we start to move away again from fee-for-service to value. But moving forward, one of the things, and I'll talk a little bit about this, I know Dr. Chandrasekhar had mentioned some lessons learned from our journey and our work would be helpful to you all. And so I'll talk a little bit about our lessons learned in that first decade. But what we did last year is we underwent a pretty significant effort to, again, take a look back and say, what did we learn over the last decade? And what do we want the Innovation Center's role to be in driving transformation in the U.S. health system moving forward in the next decade? And out of that really came a renewed vision. And that renewed vision is for the Innovation Center to help build a health system that achieves equitable outcomes through high quality, affordable, person-centered care. So I started to think about what does that mean for hospitals in particular, given the area of focus for you all in your meeting today. I would say that, we really are emphasizing in our work, including our hospital tests, model tests, is an emphasis on longitudinal accountable care relationships. So even thinking about the hospital as a place where, even if that might be the first entry point for an individual, that we're using those touch points in the health system to engage people upstream in their care so that they do have a primary care provider, they do have somebody quarterbacking their care in that management of chronic disease. We're thinking more and more about the role of hospitals also in integration. How do we make sure the full range of individuals' healthcare needs are met, all the way from their specialized care to their preventive and primary care as well? And so how are we thinking about our population-based models and our acute inpatient work? And then the third is equity. That equity is really essential to improving quality. And, in India, there's a very heterogeneous population there as well, and in some cases perhaps even more. But we know that in the United States, we have huge differences, significant differences in access to care, quality, outcomes, and mortality rates. And so some of the things that we really want to be able to do is, again, in the hospital space, focus our work so that we're increasing access and equity and driving quality for all of our beneficiaries. So that's just a little bit of the setup in terms of who we are, what we do, and where we're headed hopefully in the future. But I'll talk a little bit about some of the lessons learned as we've been testing all of these different models. And the first is, again, that we really want to design our models. We really want to be targeting and making sure that we're reaching all populations, especially those that are underserved. Complexity, I think, is another issue. I think Robert and others, I caught some of his remarks, and the speaker before that as well. But complexity is a huge thing in the United States health system when it comes to hospital payment, the DRGs, risk adjustment, et cetera. It's very complex. And so as you're thinking about moving forward, I think, creating a cohesive strategy, a cohesive roadmap for where you want your hospitals to go, and then making sure all of the different parameters of payment, of quality, all the different requirements are as transparent and easily understandable as possible. I think the complexity increases administrative burden, and we know that that's also a big cost driver in the US system. So again, I would really say, try to focus on making things as, not complex as possible, and transparency is critical. Also learning collaboratives. You have a built-in set of hospitals that you all work with through PMJAY and that you lead. We have found that actionable data learning collaboratives are really important for folks to be able to, for hospitals and participants to be able to share best practices and learn about what's working and what isn't working out there in the field. And so those are just, you know, some of the big lessons learned for us. And then I'll say some of the other places now that we're going, other folks have spoken about the current US payment system and the DRG system. I'll talk about two kinds of models that the Innovation Center is testing as we think about sort of the future of hospital care as well. One is episode-based payment models or bundled payments, where we actually have been for close to almost a decade testing a number of different iterations of bundled payment models, where we combine payments for physician, hospital, and other healthcare provider services into a single bundled payment amount for that facility that's triggering an episode. So we have some bundled payment models in the joint replacement space, for instance. We also have some medical episode models, but other procedure-based bundled payments as well. And in our testing of those models, we've actually found generally shown improvements in lowering expenditures and quality improvements. We've reduced fee-for-service payments for the majority of our episodes in those models while maintaining quality. But I will tell you, in our models are also voluntary, so they're mostly voluntary. So there's also self-selection in terms of who's coming in. So to the extent in PMJ that you have that ability to bring all the hospitals in and reduce that self-selection, I think it probably is beneficial for the system. And then the other area where we're doing a lot of testing, and this includes slightly different than the Maryland model, but the Maryland model is probably our oldest and largest. We have some rural health models in 5 different states in the United States, where we're really looking at hospital global budgets in rural areas to give hospitals, those rural hospitals that often don't have the same revenue levels as maybe hospitals in urban areas, to be able to support them through, you know, global budgets, prospective payments that give them predictability in terms of their cash flow and revenue. And the goal there, again, is to increase access, because rural communities face a very different set of challenges. We have about 57 million Americans, which doesn't sound a lot for India, is not a big number for India, but we have that many Americans living in rural communities. And they face very unique challenges, as I'm sure that you do in India as well, when people are not in urban areas, when they're trying to seek healthcare. They have more limited transportation, you see a shortage of healthcare services, and really an inability sometimes to fully benefit from those technological and care delivery innovations. And so we know that rural Americans are facing worse health outcomes and higher rates of preventable diseases than those living in urban areas. And so again, those hospital global budget models are aiming to test ways to increase financial stability for those rural providers. So again, reimbursing them with upfront investments, predictable capitated payments that again are tied to quality and patient outcomes. We're also looking at ways to remove and lower regulatory burden. Again, it's that complexity issue, that the more complex the system becomes and the more regulatory burden there is, the harder it is, especially for those rural providers. So how can we increase our operational and regulatory flexibility? Those are some of the things we're looking at. And then some of the other things we are doing as it relates to our equity goals as well is to enhance, again, access to healthcare services, and thinking about offering additional services and helping our providers identify social determinants of health. So what are those, you know, food insecurity, housing, those other things that we know are related to positive health outcomes, and how do we get our healthcare system communicating better with our social service and community-based organizations to address those whole person needs. So I'll stop there and see if there's any questions.
Thank you, Dr. Purva. Basically, to understand how do we make patient-centric efforts, which is beyond the health systems, also is also a key point to ensure that we are reaching out to the patients. I think moving beyond the global experiences, I think we have some learnings and some new initiatives which our states have taken. I think it is important to acknowledge them and see how we can scale that up even across our own states, so that wherein hospitals are being provided graded scores, and then the payments are linked based on those graded scores. So for this, I invite Srimati Uma, Project Manager CM CHIS, to present the experience in a short presentation to the audience, so that we learn some of the initiatives that are happening within India too, and how do we scale that up to improve the pay for performance to the hospitals.
So good afternoon, everybody. So first of all, I thank the NHA for having organized such a wonderful platform so that some of the best experiences we have can be shared. And also we had a very good learning experience from the other states as well, so that it can be rolled out in a very good manner. And now that we have come to a point of quantum of the share which we are doing, now we are in the process of moving towards the quality of healthcare, how better it can be able to be spread across both the government institutions as well as the private institutions. So morning I was really wondering to hear from Sir from Jharkhand and Meghalaya how difficult it is to roll out the program. But luckily from a state like Tamil Nadu, our challenges are completely different. We are living in a very, very urbanized state. We are expecting the 21 census, if it is going to be completed, our urban population will definitely be moving towards 55%. Our literacy rate is very high. People's expectation is very, very huge. And for each and every issue, we are facing so many litigations also. So among all these challenges, how best we can serve the community, how best we can take forward the program is a real challenge. We started in the year 2009. Initially, nearly 10 years ahead of the PMJAY, it was termed as Kalaignar Kaappeetu Thittam. But thanks to PMJAY in the year 2018, now we started with 1 lakh sum assured per family in the year 2008. After integration with PMJAY, government has been kind enough to expand the 5 lakh coverage to all the families under the insurance coverage. So as of now, we are catering around 1.4 crore families of Tamil Nadu. Each and every family, whether they are a PMJAY family or a Tamil Nadu government, everybody is assured a sum of rupees 5 lakh per year. So first we can see a small introduction. So we have both government empaneled hospitals as well as the private empaneled hospitals. You all know very well, Tamil Nadu is one area where the supply is more than the demand. We have 36 government medical colleges, approximately 1 per district. Then we have 28 private medical colleges and also many standalone corporate hospitals. So first to bring our hospitals on board, how well we can make them work in a very, very enthusiastic manner, how well all the equipments which we have invested through NHM, World Bank funds, JICA funds, everything is operationalized to the maximum optimum capacity with no dearth of specialists or no shortage of super specialists. We have to make them work and bring the benefit to the people, and for certain procedures still we have a long waiting list which we are planning categorically based on the district-wise availability, so that some of the gaps between the districts can be mapped and the waiting list can be brought down. So for government empaneled institutions, we pay 15% incentives out of the total package amount, so that makes the energy to the government doctors as well as the staff as well as the paramedical involved in the procedure to involve more in the procedure. And for the private empaneled hospitals, as we said, we have grading of the hospital and also differential pricing. So this is how the insurance claim amount for the government institution is being given since the year 2016. So out of the 100% package amount, 40% is reimbursed in the name of consumables. As I said in the morning, all the stent, then all the replacement, knee replacement, hip replacement, even for dialysis, we can assure that it is 100% free of cost from the public point of view, because the hospital never goes out of funds. 40% of the fund is available at the head of the institution. They can decide, and also we have fixed the price through TNMSC for the consumables. So anytime they can call the vendor and they can procure it. They need not go for any tender procedure or need not go for any quotation process. So we have liberally done this work on behalf of the government institutions. So they can straight away call the empaneled vendor and they can immediately procure the consumables, whatever it may be, including the stunt. For everything we have fixed the price. Next is the 17% fund which is given in the name of hospital upgradation. Here they are at the liberty to empanel, or they can say engage any number of staff nurses or multipurpose hospital workers, dialysis technicians, cath lab technicians, all the paramedical, whichever they are in a shortage position. They need not wait for any government order, approval, head of account, salary. It is a flexi pool fund which is available freely at the head of the institution. They can follow the procedures which we have given at the head of the hospital committee. They can very well procure, or very well they can engage any number of persons, do small maintenance work, civil work, plumbing work, toilet maintenance. They need not wait for any approval. So immediately it can be done in a very good way. Then 15%, as I said, it is for a small incentive for the treating amount, because you know Tamil Nadu permits private practice for the government doctors as well. So now insurance performance is the only proxy indicator how well the government institution is performing. Because the same doctor, he is not using the cath lab here, but he is doing lot of procedures in an institution to which he is attached as a visiting doctor in the evening hour. So this gives us lot of data so that we can see that our high investments are also put into 100% use. Balance 28% comes to TNHSRP. It is a corpus fund which is maintained with us, so that we are liberally funding up to 22 lakhs for liver transplant. Tamil Nadu is one state which is funding all the high-end transplant procedures, right from renal transplant, cochlear transplant, liver transplant, heart and lung transplant, all the high-end 8 procedures we are doing. So over and above the 5 lakh, whatever is the liability, that is paid from the corpus fund which we are generating through our government institutions. Regarding the private hospitals, these are the 3 main criteria on which the hospitals are graded. One is the general infrastructure, then human resource and the critical care availability, and the specialty-wise infrastructure. So that TPAs, they have a very good system of CMOs. So all the private hospitals which are applying for empanelment, immediately they will be subjected to the verification on these 3. We have a prefixed questionnaire. So they will be graded based on the availability of the infrastructure and all the mandatory regulations, Clinical Establishment Act, AARB clearance, all the NABH accreditation. So whatever are the mandatory requirements, every requirement will be verified, and also the human resource and critical care. Here I would like to say, because of these mandatory conditions, during COVID, we found that even in Tier 2 cities, we had very good ventilator setup ICUs. Because usually all these are focused only in the urban areas, and Tier 2 and Tier 3 are literally, they don't have much facilities. But because of repeated stress that you will not be given a higher package rate, many of the hospitals have invested in a very small way, and this helped us during the COVID pandemic a very lot in treating all the respiratory emergencies. So this is how the grading and the package rate goes. So if the hospital is able to get above 80, they will be graded as 81, and they will get 100% of the package rate. And 71 to 80 will be placed in grade A2, and they will get 90%, and the last will be up to 40 score, and they will be kept at A6 grade, and they will be around 54%. And for our convenience sake, we are not very strict with government institutions. All our government medical colleges and district headquarters hospital, we have placed in A1 score. Then single specialty, especially for ophthalmology, there also the grading pattern continues. So there it is, S1 is 100% and S2 is 72% number of hospitals. So now what is the lesson we have learnt because of this grading? Now there is a healthy competition among all the private hospitals. They feel that if you want to get a good chunk of money for their turnaround purposes, definitely they have to upgrade their hospital. Especially this is very true in terms of Tier 2 and Tier 3. I will not say that this works in a very, say, welcoming fashion in the corporate hospital, because already they have lot of waiting lists from other states, and you know that Tamil Nadu is a site for medical tourism. Even patients from abroad, since the cost of the treatment is very low in India when compared to the foreign countries, even like Apollo and so many other bigger hospitals, they have waiting list huge. But for A2 and A3, that is the category, in the Tier 2 and Tier 3 cities, definitely they improve the infrastructure, they improve the manpower, as well as all the quality criteria, so that they move to the upgradation. So this table shows that in the past 7 years, we were able to find around 697 upgradations have been done. Some hospitals with 1 upgradation, 315, and up to 3 upgradation. That is from A6, they would have moved to A5, then they would have moved to A3. So we allow that also. So repeatedly when they submit the online application and call us for the repeated upgradation, that also we permit. So there is a healthier competition among the private hospitals, so that they are able to upgrade and get a better package rate. And these are the high-end procedures which we are doing. And here one important point is, since the quality criteria and all this grading has been strictly enforced in the field level, we can proudly say that though we are doing such a lot of transplants and other things in our state, our mortality rate is well within the framework of international mortality rate. Each and every death in the higher say disease pattern, definitely it is subjected to a M&M committee, mortality and morbidity committee audit, which comprises of private doctors as well as our government doctors. So every death we audit, and if it is preventable, acceptable, it is not for finding any fault, but to improve the negligences or to improve the gaps so that this is not repeated. So because of all these quality criteria and all the gradings, the hospitals are able to do a better performance, and we are able to showcase that our mortality rate is well within the international accepted mortality rate, especially in the high-end surgeries. And this is how the share of the claims and the number of hospitals, private hospitals in each grade, you can very well see when the last 3 years data was analyzed, 33% of the total claims has gone to 10% of the private hospitals which are in the A1 grade. So out of 937 in the private hospitals, 99 hospitals are in the A1 grade, which has earned around 553 crores in the last 3 years alone. That is 33% of the total share of the claim amount has gone to the private hospitals, which are around 10%. So again, as down the line, we can see the lesser number of hospitals and lesser share of value. So definitely, it is a very, very healthy competition, so that every hospital is trying to compete with the previous stage so that they can improve and they can get the full package rate. And this is government hospitals year-on-year analysis. Then here you can say there is a small dip in the year 2020 because all the elective surgeries, everything was stopped due to COVID. And now that slowly, this is up to August, they have come to 86 crores. So we hope that they will be able to reach the pre-COVID state. And this is again A2 grade private hospitals. So again same thing, 2020 there was a dip because of COVID, all the elective surgeries were cut short. Then slowly now they are picking up. This is A3, A4 which gets 72% of the share, A5 hospital 63%. So down the line the value of the claims also goes down. Again here we have an interesting fact. So Vellore with only 2 A1 hospitals, it stands the top in the list with 84% of the total claim value has been settled for the private hospitals of Vellore. One is, you all know, that is CMC Vellore, and another one is a corporate hospital. So number of the A1 hospital doesn't play a role. Only the number of cases and the quality of care which they offer to, that is equivalent to that of the share of the claim value which they are able to get. Next stands Coimbatore, then Trichy. So as I said, ICU care has been improved across the state, critical care and all the regulatory documents they are able to do. And this year we have made it mandatory that for all high-end procedures to be done, NABH accreditation is mandated. At least within 1 year they should be able to clear the entry-level NABH accreditation. So many of the hospitals are in the process of completing this process. So these are some of the areas where we are very strict, and in the scoring pattern all these carries weightage marks. So these are the parameters in general infrastructure. The 40 mark is given for access, ramp, lift, maintenance, fire safety, biomedical. So it is self-explanatory. In-house blood bank, everything carries marks. Then again human resources, radiology means definitely there should be a radiologist to give the reports. Then intensive care, we equally divide the marks for infrastructure, equipment as well as in-house specialists, as well as the emergency department, how far it is well equipped with the equipments and manpower. And so ultimately we can say that in the recent NSSO survey, though we give equal importance for the public hospitals, our government hospitals are also running the race very fast, and our share of outpatient care as well as hospitalization in public facilities has gone very high. So that has gone from around say 34.6% to 54% as far as outpatient care in the public facilities in Tamil Nadu, and inpatient care it has gone from 34.6% to 50% across the state for inpatient care. Then again, economic and social care also, you can see in the recent NSSO survey, even the richest is moving towards the public sector, as well as everybody is having a scope that the public sector can also equally compete with the private sector in all our performances. So this is what I said in the morning. So ultimately we have to show the government so that the next capital cost and investment will be made. So definitely we have moved from 31% of the government share of insurance money in the private hospital. Now we are standing around 48%. So that government is also very happy to reinvest this money. This because 1,450 crore is our annual budget for insurance. It is a very big amount. So we expect that 50% will be available in the government institutions so that all the high-end equipments which has been invested or put into full use and utilized for the people, and we can again assure that in government hospital co-payment is definitely nil. Whereas in the private hospital, though we have many checks and balances, then and there through our call center as well as through the CM cell and all other ways, we are getting some petitions regarding co-payment, for which there is a very huge committee at the district level as well as the state level. Immediately the intervention is done, and also say punishments like de-empanelment, then again some fine, all these are taken up at the core committee level. So this is the share of the investment, government and private, and we have very good secondary care hospitals as well as medical college hospitals. Both of the hospitals are competing with each other to improve the share in the insurance amount. Thank you.
Thank you, ma'am. I think it was a very interesting evidence, especially coming in for the differential payment that you're giving to the hospitals, and it has worked, it has shown impact in terms of how it has affected the claims and the payouts to the hospitals. So I think this is a very good learning for all the other states too. To what extent it can be adopted and scaled up in your own states, that could be reviewed and considered. So I think the panel has put forth in front of all of you global experiences, regional experiences, certain specific country experiences, and we have our own state experiences. And now I would like to open up the forum for any questions that you want to ask the panelists. Yeah, Rohit.
There is a gradual decrease in the cost of implants, like you have from 60 to 40% it has come, and also for the infra you have brought it to 15%. So yes, I can see it is a mark of sustainability and efficiency. It can be a benchmark of efficiency. But two things I would like to know from here, that how you really control the consumables, like is some quality sort of efforts have been made in the public sector. The first one is this. The second one, that you are creating some corpus from the second year onwards. So what is that, the purpose of that corpus? And the third question is that you have a grading system for private sector. Why do not you have a grading system for public? And cannot you increase the incentive or maybe corpus fund based on the grading system in the public sector? So these are my three questions for you. Thank you.
So thank you, sir. So
we can take the questions for any other, and then ma'am, the panelists can answer it together. Yes.
Hello. My question is, we have discussed a lot about the sustainability in the first session also and this also of the health system, which is want people to stay healthy for the sustainability of the investments, and the government has to put forward, and for the providers it's always about the utilization of service, more hospitalizations. So how to keep a balance, and what is the role of immunization, which we all know as a COVID that kept people away from the hospitals. Also the mortality was reduced significantly. So how immunization against various vaccine preventable diseases can play a significant role in keeping people away from the hospitalization and sustainability of these schemes. So that something is my question.
Then we'll take one more question, then we will have the panelists answer if there are any other questions.
I have one question. In contest with PMJAY, whatever we have discussed till now, it's like we as an implementer, we want to increase the volume on whatever the program we are doing. But we want to increase the volume only on the people who are eligible to get the benefit. I mean, the right patient in the contest what we are speaking. But diagnosing this right patient is an outpatient care. RN primary care which doesn't come under the purview of PMJAY presently. So in this condition, how we are going to emphasize on the quality of patient selection, and this becomes very difficult if we go further on the grouping system and all, because basics go wrong. And another question is
I think we'll limit to one question, and if we have time, we'll get back to you. I think I'll ask Uma ma'am to respond first, and then regarding the primary care and the vaccination, I would request Ajay and Jack to chip in and respond to that.
Sir, as you said, for consumables, everything we have already pre-described set of conditions. That is, they should be mandatorily following the DGCA guidelines, and for every tender it is through TNMSE. So the set of specifications have been already set. So for those vendors we call for, and we have fixed the rate also. So that hospital need not do this work of calling for quotation for every cochlear implant. They cannot go and do this work. So the rates have been prefixed both for government as well as for the private hospital, and all the specifications in terms of quality, everything, we follow the guidelines which has been in practice through the TNMSE with all set of experts. Second one, you are asking the corpus fund, how it is being utilized. As I said, the sum assured per family per year is 5 lakh. Suppose 2 children in the family has to do cochlear implant, definitely the package will be over by 5 lakh. So over and above the amount, the excess amount will be at the discretion of the project director, and we have the eligibility to release the over and above for the insurance patients. Also, I said we are supporting up to 22 lakhs for liver transplant, and again bone marrow transplant 17 lakhs. So all the high-end packages which are over and above 5 lakh, as well as when the sum assured for the family is over, we can release from the corpus fund, which is an extraordinary fund which is available, easily available, and it can be immediately given for the rescue of the patient. Then third one, diagnostics, somebody was asking. Sir, in our packages we have given that any diagnosis which is done within a period of 1 week before the surgery, that cost will also be included in the package cost.
Thank you. Over to Ajay.
Excellent point regarding the vaccines. So let me repeat the concept of ambulatory care sensitive hospitalization. So when you're looking at quality of care, you don't want to just look at what's happening inside the hospital. It's who's coming into the hospital, what's happening in the hospital, and then who goes out, right? So one of the components of ambulatory care sensitive conditions are conditions that if you had good primary care, you wouldn't be hospitalized. And one component of ambulatory care sensitive conditions are vaccine preventable. So you want to also try to make the links and try to first understand, are you getting more and more hospitalizations for conditions that were potentially preventable if they had been vaccinated, including, you're completely right, COVID. It's COVID will hopefully become an ambulatory care sensitive condition. But there are other conditions as well, right? Measles and others that one shouldn't have to take a look. So the linkages, I think the broader point is what happens at the inpatient level has very strong linkages with what happens at the primary care level, and the two cannot be separated. I think that's also the point that was being made. And so in the current system, in India's system, the idea is the health and wellness centers will take care of the primary care, and the PMJAY takes care of the inpatient. But I think the closer the two parts of components of the system work together, or perhaps if, as has happened in Tamil Nadu, if the benefits package is expanded a little to include some outpatient care, so that that continuum of care it doesn't create a barrier from the patient perspective. So, the system might be there, but the patient also can, you don't want to have confusion for the patient as to where to go and who to go to and which program covers what reimbursement. So trying to remove some of that complexity and some of that fragmentation would be one way to move forward. And some states, just as they have expanded population coverage, may also want to consider experimenting with expanding the benefits package to include primary care.
Thanks, Ajay. Jack, do you want to add?
I'm just going to add one simple message to what IJ has said, which is make sure since this is a session on incentives, make sure your incentives at the primary and secondary and tertiary level work with each other. One country I worked in, there was capitation at the primary care level. That incentive encouraged referrals out. And then you had a hospital that was paying fee-for-service, and that encouraged the hospital to say, yes, we would love to have you because we're paid on a fee-for-service basis. So you need to make sure that your incentives across levels of care are working together. I would say that with DRGs, both capitation and line item budgets might be very suspect at lower levels of care because it could encourage those primary care level providers to refer up too quickly, and then there's an admission that might not be necessary.
Thanks. I think we will move to the concluding part of the session, and I request Trina to summarize the key points from the session.
Thank you very much, Dr. Sudha. I was taking notes, but I won't try to summarize fully, but just maybe mention a couple of key takeaways for me from what was an extremely rich set of presentations and also penetrating questions from the floor. I think we started with a definition of what quality is, or what quality can mean, and it has several different aspects. So we need to look at all of those if we're going to really make quality and people-centered care at the heart of PMJ. So structural quality, clinical quality, and also process quality, all coming together. So that was a starting point. But one of the things that, next things that struck me is what Jack said, which is that we really need to do it ourselves in our own ways and not necessarily wait for any imported model per se, but really look at what kind of challenges your state is facing and then take up some kind of a pilot to test what needs to be done and what could be done to improve quality and strategic purchasing. Do it yourself. I think I wrote down what he said. Yes, do it yourself. Do not contract out, is what he said. So please do it yourself, and let's see what kind of data, what kind of results you achieve as a result, and share your results widely. The other point that I think was made is that we need to give these things time to really be implemented and generate the results and then tweak the systems going forward. One very important common theme of all of the presenters, including Dr. Uma from Tamil Nadu, is that we need data, and we need to utilize that data in order to analyze what is happening in terms of changing behaviors of providers. What impact are these provider payment systems having in terms of service delivery, in terms of quality, and in terms of health outcomes? Ajay, I think, started by pointing out that many systems reward or make payments if the provider can show that the patient is sicker, whereas actually what we should be incentivizing payments on is whether the patient is healthier at the end of the day. The data that is available in almost all of our systems at the state level through PMJ is huge in terms of allowing us to do that. Dr. Murray also mentioned looking at ambulatory care sensitive conditions. Actually, everybody mentioned that we can use our data from PMJ and from our hospital systems to really look at what is it that is leading to, what are the conditions that are being paid for at the hospital level. Are there potentially preventable hospitalizations that are taking place? And that information and that analysis will give us pointers of where the primary healthcare system needs to be strengthened further so that they can capture those ambulatory care system, services earlier and in the primary care system, and so they do not need to end up in the more expensive hospital-based system. But in order to do that, we really need to constantly be looking at our data and, in fact, have the IT-based data systems that will allow us to do that analysis. We also heard from Dr. Purvia in the context of the United States, really, what they are doing, and they may have a lot to learn from the Indian case as well. But what they are doing is they are constantly testing different models. And there is a focus on trying out models that are designed to better serve disadvantaged groups. So tailoring the model that you are going to test to different beneficiary groups or different types of conditions. She also mentioned a rural care model that is being tested out because the conditions in rural America are significantly different from urban America. And I'm sure that is the case here, even more so. So data, homegrown models, testing, linking provider payment to healthy outcomes for people, and then using the savings that are generated to top up benefits for disadvantaged groups. I think that Dr. Uma has really pointed out how much that is working in the Tamil Nadu case. So these are some of my key takeaways, but it's very exciting because there is this huge amount of data and available for us to do this work. Thank you.
Thanks, Gina, for ensuring that you summarized the whole session well. Before we close, just want to also request all the panelists to release our publications on our ICD-ICHI integration. For any advanced provider payment systems, it is important that we need those ICD coding and the ICHI coding. So in that sense, we had launched this in April, and we have our 6 months experience, and I would request Dr. Grace and Dr. Shankar Prinja also to please join us on the stage to release this report, which actually is a good learning for various other countries also to see how do we adopt the systems, because this is one of the latest coding systems and India is one of the first country to adopt it in our health insurance scheme in the world. In that sense, this is a big achievement, and this has been possible only with all the help that we have received from the states to use it, integrate it, train their grassroots workers at the hospitals and all the providers who have ensured that they have been a significant member in this effort. So I'd request the GIF to be played, and at the same time we will release the hard copy of the publications too. Thank you, everyone. Over to Priyanka.
Thank you everyone for joining us for this session. I would now like to invite Dr. Sudha to facilitate Dr. Trina. I would now like to invite Dr. Trina to facilitate Dr. Ajay Tandon. I would now invite Dr. Trina to facilitate Dr. Jack Legenbrunner. I would now like to invite Dr. Trina to facilitate Dr. S. Uma. I would now like to invite Dr. Trina to facilitate Dr. Robert Murray. I would now like to invite Dr. Trina to facilitate Dr. Grace. I would also like to request Dr. Trina to facilitate Dr. Shankar Prinja. I would now like to invite Dr. Trina to facilitate Dr. Sudha.